Hi, thank you, Dr. Sclafani. Yes, I'm Diana Driscoll. I have my financial disclosure statement there. Um, and you may know me as Dr. Diana, as patient, and I am pretty ill. I am so excited to be here and speak in front of such a prestigious crowd. Thank you so much for having me. And I think in order to get my foot in the door here, I had to have a gimmick, right? So what is my gimmick? One, I have Ehlers-Danlos syndrome, which is a defect in my collagen. It results in loose joints, but it also results in fragile and leaky vessels, permeable blood-brain barrier. Basically, I am more prone to developing multiple sclerosis, as are my other EDS brethren. So I have autonomic dysfunction, or what we call POTS, postural orthostatic tachycardia syndrome. I have mast cell disease. I have CCSVI and have been treated with angioplasty. Those are what my wonderful husband would call lovingly my jugs. I have one brain lesion, and I was developing symptoms of multiple sclerosis. Now, many people didn't realize there is an overlap between Ehlers-Danlos syndrome and multiple sclerosis. More people with Ehlers-Danlos do go on to develop multiple sclerosis than in the general population, but there is also a 10 to 11 times increased prevalence of Ehlers-Danlos in MS patients. And every time I go to a conference, say for example something like this CCSVI conference, I'll meet a great number of MS patients. I will find one or two that have Ehlers-Danlos that's undiagnosed. When I go to an Ehlers-Danlos conference, I meet quite a few people who have multiple sclerosis. I kind of, with my angioplasty, was trying to figure out what was causing this backup, if you will, of blood. Why all of a sudden had my weak vessels suddenly become less effective? So then I was thinking, being the eye doctor, a therapeutic optometrist on a professional disability, by the way, but thinking, could this backup in my internal jugulars go all the way up to the back of the eye, the fundus of the eye, and actually show up by looking very closely at the fundus of the eye? And I did as what most very good scientists do who are affected by the disease, and that is I grabbed my own images first and took a look. And first everything looked okay, but I just kept magnifying it, and boom, there it was. So I started a clinical trial looking for evidence of CCSVI in the fundus of the eye. This is a normal fundus. Very briefly, what we're looking at here, of course, you see the optic nerve and the macula there in the middle. But looking at the vessels, the veins are the larger, darker ones. The arteries are the smaller ones. What we want to see is an AV ratio, artery to vein ratio, of approximately 2 to 3. And this is a normal fundus, and that is indeed what we see. I also wanted to make sure I reviewed my anatomy. Does the internal jugular indeed do the veins go all the way up into the back of the fundus? Yes, indeed they do. They start at the capillaries of the retina, go on through cavernous sinus, as you see here, down into the internal jugular vein. That was important to know. It was amazing how difficult it was to find this information because the arteries seem to get all of the attention, as you know. This is my image, my fundus image that I first pulled up. And again, in a backed up view, it looked perfectly normal. But if you can tell, let's look on the left, that dark vein there, that looks too big. And the artery right next to it looks a little too small. Basically, the AV ratio does not look right. Now, if you look on the right-hand side, that is my right eye, indeed, that vein looks not only too large, but it looks beaded. Very similar, if you will, to what we see in CCSVI with a vein that is not draining properly. And the difference in the AV ratio in that eye indeed hints at poor venous drainage in that eye. This is another one. Whoa, that's very dark. I hope you can see that. This is another patient with Ehlers-Danlos and multiple sclerosis, and indeed you can see the same presentation in those large veins that do not appear to be draining properly. You can see some evidence of stenosis there on the left-hand side at about 7 o'clock and at about, oh gosh, what would that be, 3:30? So, and the same picture is on the right-hand side, but again showing the larger size vein. One other patient I looked at was very disabled, and I pulled back on this image to show you what really grabbed me. Try to ignore that large vitreous floater, although that is impressive right there in the middle. I looked at her image and thought, holy cow, where are the vessels? We do see the choroidal vessels under the retina, and those look okay. But looking on top of the retina, if you will, at the arteries and veins, they almost aren't even there. And I thought, if this is the perfusion that's getting to the back of the eye, what kind of perfusion is getting into her brain? And also, the size of those arteries are so small, I asked myself, is this a stroke waiting to happen? Finally, what it made me think of is the patients that CCSVI is performed upon, and that on the table, these patients say immediately they feel like they have super X-ray power vision. It's like it went to high def, if you will. Were we indeed increasing the perfusion of the retina? And my guess is yes, but I'd love to see some images when that happens. The other thought I had is if the blood is backing up and we can see that it's not draining well from the fundus of the eye, it must back up and cause some pressure inside excuse me, the cavernous sinus. And the cavernous sinus is unusual in that it is bordered on one side by a temporal bone, the other side by the sphenoidal sinus bone. And it has 5 cranial nerves running through it, as you can see here. It also has the internal carotid artery. Now, if the venous pressure is building up because of poor drainage, it's not going to harm the internal carotid artery. The pressure is just too high there. But those cranial nerves are delicate, and if the venous pressure is high, putting pressure on those delicate cranial nerves, I could understand that we could see some intermittent, perhaps, subtle symptoms that are affected by the pressure on these nerves, and probably ischemia of the nerves. And these symptoms would likely wax and wane. 3 of these cranial nerves involve eye movement. So perhaps we would see some intermittent double vision, or say looking to the side using our lateral rectus, cranial nerve 6. We would see double vision or almost double vision there. I myself experience fighting double vision, and had an episode, or a few episodes, where I would look to the side, say at my car radio, and looked as if it was moving away from me. And I knew that was a partial paralysis of the lateral rectus muscle, because it changed the depth perception. So that's just kind of the geekiness of having a bizarre symptom, being able to figure that out. So I would like us to look at some of the potential symptoms these patients have and see if indeed they are indicative of increased pressure in the cavernous sinus. Also, those other 2 nerves could cause increase in deep facial pain and sinus pain where there is no sinus infection. And I myself have experienced both. And it is not subtle, my friends. It was severe and yet intermittent. So it relates back to what we would consider, say, a low-level cavernous sinus thrombosis, if you will, which can cause a venous stasis retinopathy. Things aren't moving. The blood on the fundus is stagnant, and that can cause this sort of presentation. So there's a great article there mentioned. Now, this also got me thinking. A lot of Ehlers-Danlos patients exhibit symptoms basically from birth. Now, these are not symptoms that necessarily alarmed doctors, but as time went by and we developed disabling dysautonomia or POTS, I realized that no one had looked back to see, when we were babies, what was happening or what could have been happening to cause these symptoms. I went on to develop, very obvious to myself, high intracranial pressure, as did my children. And then talking to hundreds of patients, which, thank you so much. Who doesn't love social media? My goodness. I was realizing that this was very likely a slight level of too much pressure on our brains, intracranial hypertension, perhaps from birth. And if so, this should show itself by looking at the head circumference growth in the first 15, 16 months of life before the closure of the sutures of the skull, and started this study. And again, it's at clinicaltrials.gov, just wrapping it up now, and pretty exciting results, I've got to tell you. At this stage, you can see in blue, our head circumferences on average went from about 40% to close to 100% of normal, using CDC's 2008 data of normalcy, if you will. That is not normal, my friends. It shouldn't change like that. So that's leading us down some exciting roads. Very quick review of CSF dynamics. I know you understand this, but I myself had to review it too. The CSF is produced there in the choroid plexus. It drains through the third, fourth ventricle, down the spinal canal and back up and around into the subarachnoid space up above the brain, and out, hopefully, through the arachnoid villi, into the superior sagittal sinus. Basically, some goes out through the lymphatics, outflow, etc. But basically through the arachnoid villi, and then to the sinus, out the transverse sinus, and away you go, and through the internal jugular vein. So, as my pressure became more and more obvious to me, and it was just purely symptoms of pressure, I could tell, and I took also a medication that increases blood volume, which is often used for POTS, and made that headache a gazillion times worse. I grabbed an expired bottle of Diamox, which every good eye doctor has in the back of their cabinet somewhere, because we need it for emergency closed-angle glaucoma patients, among other things. We hardly ever see these patients, but we have to have the Diamox available to quickly, or as quickly as we can, decrease some of the pressure in the eye, and it also decreases the intracranial pressure. It also is a mild diuretic. I popped a couple of those out of absolute desperation because the pressure was just killing me. And lo and behold, my symptoms were gone the next morning. So continued to use acetazolamide and continued to improve, but still had symptoms. And I thought something is still missing. And the missing piece from my research, I truly believe, is mast cell disease. Mast cells can cause leaky and weak varicose vessels. They release over 60 very strong chemicals, including histamine, which is a big one, tryptase, prostaglandins, leukotrienes, and cytokines. Now, we already know that mast cells are related to MS. Research is already out. And I realize also that many of us don't have normal mast cells. Abnormal mast cells look kind of funky. They grow too fast. They don't die as early. They tend to accumulate. It can even extend to something similar to a cancer, if you will, and can actually be deadly within a year or two, which is really scary. But fortunately, that's kind of rare. Mast cells love to hide out in our organs, our lungs, livers, GI tract. Oh, yes. Gluten intolerance, IBS symptoms, absolutely. They go to the lymph nodes, the skin, kidneys, eyes, where we would see granulomatous uveitis, pars planitis, which is very common in multiple sclerosis, incredible dryness and itching. And they go into the brain. Now, triggers for mast cell degranulation, I can't help but notice this overlaps with quite a few triggers of multiple sclerosis. Heat, exercise, hormones, positive or negative emotions or stress, certain foods, their colorings, flavors, alcohol, caffeine, certain smells, etc. So here we go. We can tie it all together. Now, in the brain, mast cells can cause brain fog, dementia. Some people say it's brain fog, but I am here to tell you I have been there, and whoever calls it brain fog has not had this condition. It is dementia, my friends. Changes in personality. Many of us describe it as a bipolar presentation, and I had that for 2 weeks where it was extreme, and I could identify that my responses to stimulus, be it good or bad, was not in relation to the stimulus itself. It was over response, but I still couldn't control it. We call it organic brain disease. Extreme fatigue. This is a great picture. Thank you, Dr. Sclafani and Dr. Gabbiani, for these beautiful views of collagen 1 and collagen 3. Mast cells are changing the collagen in our vessels to this looser, weaker type, if you will, in varicose veins. Mast cells love to hide out in the choroid plexus. My friends, this is where we produce cerebrospinal fluid. So if the mast cells there are stimulated to degranulate in the choroid plexus, they could absolutely stimulate a sudden surge in cerebrospinal fluid production, which I have also experienced. And then that leads to a domino effect, which I can go into. Certainly we see that in hyperadrenergic postural orthostatic tachycardia, which is one of the syndromes I have. Waste products can accumulate around the brain because we're not draining things. As you know, we have to get the bad stuff out to get the good stuff in. Okay. We are at, I believe, this tipping point where we can accept a certain level of increase of intracranial pressure and still be okay. But you get to this point, shown by this little arrow, where any increase in intracranial pressure displaces a great volume of brain tissue. And this is bad, bad, bad. So this ties together mast cell disease, the reasons for CCSVI to occur and involve the conversion of collagen 1 to collagen 3, why our blood-brain barriers are leaky, what is happening to the arachnoid villi. We didn't go into that very good detail. I need to get back to that. The cause of granulomatous uveitis and pars planitis in MS patients, why MS symptoms can wax and wane, the cause of extreme fatigue, brain fog, dementia, GI symptoms, and numerous other ocular symptoms, and the cause of optic neuritis. Again, I didn't get to touch on that, but that's all tied in. Wanted to just breeze through really quick astrocytes. One, because they're so pretty, aren't they? They are intertwined with the neurons, axons, and myelin, and brain capillaries, of course. They help make our blood-brain barrier tight and non-leaky. Interestingly, they can produce pro-inflammatory cytokines and stimulate it. They also can respond to cytokines, which is not a real good cycle to get into, because after cytokine release, the immune cells can actually invade the brain and activate these astrocytes, which results in apoptosis and gliosis, as we know is not good. So you get this compromise of the blood-brain barrier, which causes fluid in the interstitial space, which leads to vasogenic cerebral edema, which leads to an increase in intracranial pressure, which then can cause the collapse in brain capillaries, an arrest of cerebral perfusion, and then, ironically, which damages the astrocytes, which can cause, again, back to the circle, compromising further the blood-brain barrier. The damage to the astrocytes also will occur with damage to neurons and myelin. This is a very vicious circle. You can see how the use of a carbonic anhydrase inhibitor, such as acetazolamide, can break certain parts of this cycle. It can remove some of the fluid in the interstitial space. It can take out some vasogenic cerebral edema, lower some of the intracranial pressure, hopefully allow the brain capillaries to be restored, and can arrest this vicious cycle with a lack of cerebral perfusion. Final considerations, and these are things to think about. Should we screen MS patients for Ehlers-Danlos? 90% of Ehlers-Danlos patients are never diagnosed. I think, yes, it is a fairly easy screening tool, the Beighton scale, to run people through, and it's amazing what you'll find. You certainly do not want to do angioplasty on a vascular Ehlers-Danlos patient. The first person to find one of those and miss it and perform angioplasty, they are going to wish they had ran a Beighton scale. Should we consider a trial of acetazolamide to reduce intracranial pressure for symptom reduction? Yes, especially in patients who either can't have angioplasty, had a partial response to angioplasty, can't afford it, what have you. I absolutely think that could be a good Band-Aid. Should we consider acetazolamide prior to CCSVI angioplasty to allow more influx of oxygenated blood into the brain, potentiating the effects of angioplasty? Of course, I think yes. Yes, we should. We should certainly consider mast cell disorders in multiple sclerosis patients. I've just had too much success not to consider that. And also, mast cell mediators could be some of that the cause of restenosis. I think we can cut down on the numbers of restenosis that we have by addressing mast cell mediators. Mast cell patients are not easily diagnosed if they don't have cutaneous signs. You may not know it, but it can certainly be figured out. And even the trial with an H1 and H2 inhibitor is easy sneezy to see if that just helps them feel better. The protocol for mast cell activation syndrome has changed, and yeah, as you'll find out, I'll discuss that in another presentation, I guess. But anyone who may have mast cell disorders, I would recommend pre-treatment. And especially, I do think we need to address the post-angioplasty protocol on trigger avoidance to prevent restenosis. I think that protocol after the procedure needs to be very rigorous. The patient needs to be very rigorous in following it, let me put it that way, because rest is extremely important. One of the strongest triggers for degranulation of mast cells is stress, be it good stress or bad stress. But then the other trigger avoidance, I think, is critical. Even the procedure itself could cause mast cell degranulation and needs to be addressed. Of course, we have to understand that people with mast cell conditions do run a risk of anaphylaxis, and we need to be ready for that should that occur. And remember, if all else fails, reach for what you know, and that is duct tape. All this can be found with much more information, my clinical trials, handouts, videos, etc. on prettyill.com. I want to thank you for your time and attention. I appreciate every one of you. Thanks so much. Bye-bye.